topic, immune checkpoint inhibitors in Hodgkin and non-Hodgkin lymphoma. We know that for patients with Hodgkin lymphoma who are refractory or relapse after first-line therapy, a transplant is an option, but for patients who fail transplant, they have a very dismal prognosis with no more than 2 years overall survival. And salvage chemotherapy in this group of patients controls disease for a very short time. So we're in need of a new standard of treatment for patients who are refractory or relapse after autologous stem cell transplantation. For decades, the oncology community has been trying to optimize the power of the immunologic system to achieve better treatment responses. And we see that when tumor cells encounter T cells, they interact through a PD-L1, PD-1 interaction, and this interaction inhibits T lymphocyte production, inhibits cytotoxicity, downregulates the production of cytokines, and enhances the susceptibility to apoptosis. And this will lead to inhibited anti-tumor immunity. Like it was said before, it puts on a brake on the immune system to fight against these tumor cells. And Hodgkin lymphoma is a good disease, thinking on attacking the immune infiltrate, because it has few tumoral cells, but an extensive but ineffective tumor infiltrate. So we are here facing this new era of checkpoint blockade therapy with these new drugs, the nivolumab and the pembrolizumab, who are fully humanized IgG4 monoclonal antibodies that block this interaction between PD-1 and PD-L1. So they take out the brakes and they restore anti-tumor immune activities. This is one of the first presentations on these clinical trials presented by John Timmerman in the ICCML in 2015. And the response rates for patients with relapsed refractory Hodgkin lymphoma was 87% overall response rate with a 26% complete response rate. So these were really amazing results. And these drugs are also active in non-Hodgkin lymphoma. They are less active, showing a 36% overall response rate for diffuse large B-cell and 40% for follicular lymphoma. The complete response rate were 18 and 10%, so they are active drugs, maybe not as active as in Hodgkin lymphoma, but they are showing some responses. And pembrolizumab in relapsed refractory Hodgkin lymphoma also showed a 65 overall response rate with 16 complete response rate, being a little bit more active in patients who did not go through transplant, who did not fail transplant. I think this is an interesting slide. This is each curve is each patient in the trial showing the way they responded. So some patients achieve very quick complete responses. Some patients have stable response. And as we go throughout the year, they all show different time of response to this new drug. So we have very unpredictable pattern of response. And this is, I think this is a new challenge for hematologists to consider when these patients are in response, when we should evaluate them. Here we see the same in a different way. In the blue lines, we see patients who are in complete response, and I circled in red the time at which they achieved their first response. So for the first two patients, they had a very, very quick complete response, considering these were patients who were relapsed or refractory to many lines of therapy. And in the last 3 lines, in the last line, we see a patient who had a partial response for a long time and achieved a complete response after stopping therapy. So this is something new for us. And in the other 2 lines, we see patients who had a partial response for a long time. They kept on going with chemotherapy, and they finally achieved not chemotherapy, with this therapy, and they finally achieved a complete response. So I think this is we are facing a new challenge. Our last recommendations on how to evaluate non-Hodgkin and Hodgkin lymphoma were published with the Lugano classification. But what about this kind of therapy? We see very quick responses responders, and we see very late complete responders. We also see very quick early relapses and long-lasting partial responses. So we are facing a new kind of therapy, and how or when should we evaluate these patients? When is the best time to assess response? When should we consider a treatment failure? And also, is partial response or stable disease good enough? Because some of these patients achieved a clinical benefit by having a long-lasting partial response. Should we consider this a bridge to transplant, or is partial response good enough? And is allotransplant safe after this kind of immune therapy? Also, something that it would be good to know is if we have valuable predictors of response, is the PD-L1 expression a predictor of better response to this kind of therapy? So I think we have many things to learn on this type of therapy. Also, adverse events are something that we should consider. Most of these adverse events are immune related, and they are generally well tolerated, mainly in blood, skin, GI, pulmonary, and infections. But although these adverse events tend to decrease in frequency as we continue through therapy, some of them are very bad adverse events even after 6 months of therapy. So I think that education on the diagnosis and treatment of these adverse events is necessary, because many times they can be confused with other type of disease, mainly because they are immune related. So what is the future of nivolumab? Is this good enough as monotherapy? So these are future trials. It's nivolumab after failure to transplant or after failure to brentuximab. And in the last line, I think there's a trial that can answer us whether we need to go on for nivolumab forever, or whether we can stop nivolumab when patients achieve a complete response and retreatment if they relapse. Also, can this be combined with conventional chemotherapy with these benefits? And also combining different types of CBT, or combining it with other different therapy, like there was a publication combining it with low-dose radiotherapy in multiple myeloma, and also the combination of CBTs with other immunotherapies. So I thank you. This is all, and I hope you have...
So I was going to say that I think that NS Hodgkin's disease is a little bit of a poster child for the use of these agents. One of the molecular events that occur in pretty high frequency, around 40–50%, is you see amplification of the 9p24 locus, and that's what turns up JAK signaling, but also PD-L1 and PD-L2. And, I think what is unique about NS Hodgkin's is you've got generally very few tumor cells surrounded by rosetting T cells. And you really do get the notion, and people have thought this for many, many years, that the immune system was trying to control it. But I think that all the data now coming out with these agents and the ability to get these people even into CR, I think is providing the first clinical evidence that this is probably what is actually going on. It's also interesting, and I alluded to this earlier, that primary mediastinal and NS Hodgkin's are very close cousins. And they both share about the same frequency of the 9p24 amplification that leads to increased PD-1, PD-L1, and 2. However, at least the early studies so far have not shown nearly the activity of these drugs in relapsed primary mediastinal. Whether or not that's because we're curing most of the people that actually seem to have some that have this 9p24, I don't know. But it just goes to show that there probably is a difference above and beyond that. And when you look at primary mediastinal, you see sheeting out of tumor cells and not that many T cells, whereas in, again, NS Hodgkin's, it's usually the opposite.
Anyone aware of any experience using these in somebody who, a refractory patient who's actually already had an allo transplant? Because of the, concern.
I don't want to say too much, but as I do remember, I think it has been done, and it has been done without, interesting complications. They were able to do it. And again, I'm remembering from kind of conversations, so I would be very careful with what I just said there. But I think it is just in the same way, though there's a lot of worry with these agents in people with autoimmune disorders. The melanoma groups who've used a lot of these agents, they'll have a patient with metastatic melanoma, widely they failed whatever therapy. What option do they have? And they have a history of rheumatoid arthritis or lupus or something. They've treated these patients, and generally they've said it's been able to control it, and if something flares, they treat the flare, but they'll die of the melanoma very quickly if not. Hodgkin's a little different setting than that, but I think there's a lot we have to learn yet, but some of these can. And I think what I'm hearing from some of them is there is so many breaks on the immune system, though this is one of them, that in many of these settings they'll put on another break. That's why ultimately it seems like these have a percentage that might have long-term cures, but that it's going to be some kind of combinations that ultimately are going to be required to get these numbers up to where we would really hope they can be.
So I can say that our allo transplant group came to me about 6 months ago, and they had transplanted with allo a Hodgkin's case, and they relapsed. They had tried everything. So I said, okay, well, why don't you go ahead and try one of these agents, because they were going to die, and the bottom line is they're now in CR, and they didn't have a flare. So I mean, but that's one case. So I think that if you at the current time select people that really have no other options, it's certainly something that you should consider using.
I think it's also interesting to see what is the goal of our treatment with this monotherapy. Are we just wanting to make Hodgkin disease a chronic disease and patients will go on forever, like like CML or like ibrutinib, or do we want an allotransplantation or to add something else to achieve a cure? But no.
I think that we can learn a lot from a lot of these EBV-driven tumors, that when they start out, they're probably under some immune regulation, but if you don't clear them, they eventually get additional hits. So my concern would be that, with these as single agents, I think if you get somebody who's in a CR, that's different. But if you're maintaining somebody over long term with these agents as a partial, I would think that over time, some type of immune escape would happen.
I would agree with that. I also think that you probably, with these agents, if you have cured them, you're not curing them 2.5 years later. I think even some of the partial response, I think the long-term partial response is probably because if you talk to a lot of people with the solid tumors, they've biopsied some of these and there haven't been cancer within so I think we will get it. We just don't know what that time frame is, but I don't think you need to inhibit this pathway forever. I think you inhibit it for a period of time, you got it, and then it's going to be a stop. So I think these are going to be a 1 year, maybe a 1 year or something like that. But CTLA-4, which cures melanoma, is only basically 4 months, and that's all. Now that's because that's all you could give, but it cures people, so some, yeah, 15, 20%.